Good morning, everyone. We are going to get started in about 2 minutes, so just hang tight. You should be muted and your video should be off. We'll start in about 1 minute. All right, good morning, everybody. Thank you for joining us today. This is day 2 of our virtual North Country Telehealth Conference Week. Our theme this year is Uniting the Future of Population Health and Virtual Care. Although when we made this theme, COVID hadn't hit yet, so I think we're already out that future state. My name is Katie Cook. I am the Telehealth Project Manager for Adirondack Health Institute. All of the sessions this week are brought to you by the North Country Telehealth Partnership, which is a joint effort since 2015 between Adirondack Health Institute and Fort Drum Regional Health Planning Organization. This morning's session is Hybrid Care Delivery, the Best of Both Worlds, featuring Christian Malaster from Ingenium Digital Health Advisors. We do want to give a sincere thank you to all of our past sponsors. For those who don't know, this is the 6th year of the North Country Telehealth Conference, and although we would love to be up in Lake Placid this year, we hope to be in person next year, and we know that this event would never be possible without all of the organizations represented on this slide, so thank you. A few housekeeping items to go over before we start. You should be muted upon entry, and please make sure that your video is off. To avoid an echo on your end from us speaking, make sure you've chosen either the computer audio or the phone audio to avoid that echo. For optimal viewing, we do recommend using the side-by-side mode for the video. And to activate that, you would click on View Options at the top center of your screen and choose side-by-side mode from that drop-down menu. In terms of Q&A, please use the chat function to freely submit any and all questions, technical or for the presenter. We will be monitoring that and saving most questions until the end. All of the presentations, slide decks, and recordings, this is being recorded, will be archived on our website by October 9th. So please check back to the conference website if you want to access the slide deck or recording. I'm now going to introduce our speaker this morning. So Christian Malaster is the founder and president of Ingenium Digital Health Advisors, where he and his expert consortium partner with healthcare leaders to enable the delivery of extraordinary care. He optimizes telehealth services for health systems and physician practices as the interim telehealth program director. So I'm going to turn it over to Christian. You can go ahead and share your screen.
And unmute my microphone. Good morning, everybody. Thank you for joining here on this nice fall morning. I so wish that we would be out there in Lake Placid as well. I'm happy to be with you here today. It seems like this presentation garnered a lot of interest, and obviously we are in a very new world here and have to figure out how to offer hybrid care to our patients. I have worked a lot in rural health areas, and I know that the audience is largely rural. Those of you also as extroverted and interactive as I am, I do encourage you to actually keep your video on, keep your microphone muted, but I would love to speak actually to an audience of some people. I'm rather a person that likes to make a few jokes, and so it's nice to see if those land. Thank you so very much. There we go. Wow, look at all these people. See, that's what makes it so much nicer. So thank you very much, Jared, Finn, Kathy, Melissa, the people that I see here on my screen for doing that. So wonderful. And there's some more. Great. So keep yourself muted. Use the chat function to just post your questions as you go. If I catch them, I may respond to it right away, but we have some time set aside, and any technical questions, as Katie was just saying, do that there. So thanks again to the organizing committee. It made it very easy on me here to prepare for this presentation. And without further ado, let me move forward here with the contact. A little bit about me that wasn't mentioned in the nice introduction is that I was born, raised, and educated in Germany, trained as an engineer, and came to the US in 1998, and have spent the last 20 years in healthcare, first at the Mayo Clinic in Rochester, Minnesota, and then for the last 8 years running Ingenium Digital Health Advisors, which is a digital health and telehealth strategy and implementation consultancy, focusing a lot on our work with rural health systems and rural healthcare delivery organizations. We have a team of advisors, all consultants in their own right, but we collaborate on larger projects, and a lot of them have great expertise in deep subject matter expert areas like digital health law, something like that. So we bring some breadth and depth to some of the engagements if and where it is needed. But without further ado, here's the agenda now for today. So I'm going to start off with defining telehealth. Then what are the goals for hybrid care, and what's the definition actually of hybrid care? Why do we need hybrid care? And then how do we implement hybrid care? We'll have some opportunity for Q&A, and then I'll wrap it up at the end here and give you another bonus insights to help you to optimize your telehealth and virtual care offerings. So with that, everybody agreed until somebody defined it, is something that I learned by way too many committee meetings at the Mayo Clinic, where we were rehashing topics over and over and over again until somebody actually took it down. Well, what do you mean when you say telehealth or virtual care or telemedicine, right? And so very early on settled on some definitions, very pragmatic definitions, not the long 3-paragraph long ones from HRSA or that. For me, telehealth is simply delivering healthcare at a distance. It's anything that the patients, when they interact with us, that's what they're doing, and whether receiving some form of care or they're organizing their care. So telemedicine then is a subset of telehealth, and it's about practicing medicine at a distance. It's the physicians, the clinicians interacting with patients either directly over video or asynchronously over secure text messaging, or maybe through remote patient monitoring. And what we have mostly been practicing here during the COVID-19 crisis, especially if you didn't have really telemedicine set up as a service in your organization, is what I would call more remote care. And it was more about connecting with patients at a distance. What I mean by that is that a lot of organizations that I've worked with start out with like 95% of their telemedicine visits being telephonic only, which I think was exactly what was needed in March, April, and May to really make sure that we can connect with our patients. But nowadays, as we're moving now into the 7th month here in our response to this crisis, we really need to incorporate more of the visual components, because that provides more opportunities for better medicine, better care. To put this visually then, that's the taxonomy, how it puts together telehealth as the overarching umbrella term, and then teleeducation, maybe pre-surgical education, post-diagnosis education, the patient portal, downloading medical records or seeing the notes or seeing your immunization records, Those are all activities that our patients think about when they interact with us. And then we have interactive patient care there for telemedicine, remote patient monitoring for the continuous or periodic monitoring of vital signs for chronic care management or for readmission prevention, and then store and forward. So faxing an EKG is telemedicine, as is obviously sending a picture of your tick bite, asking whether you should be concerned about this red ring that is just expanding on an hourly basis. So why are we doing telehealth? For me, it has always been about the quadruple aim of telehealth. The Institute for Healthcare Improvement some years back came up with a triple aim of improving patient satisfaction, achieving better health outcomes, and lowering the cost of care, that really being the driver for any improvement within a health system. And then very quickly, some smart people added the fourth aim of improving provider satisfaction. That, incidentally, is actually my kind of core focus and core passion. Is I see telehealth as a great opportunity to redesign the workflows and the processes, how we can deliver care. There has been a lot of dissatisfaction on the clinician side with the use of technology, the EMR, and the workflows. And so I always see telehealth as a great opportunity to redesign it, and hybrid care is an excellent opportunity to do that as well. So really, telehealth is moving. The aim is achieving all of those four aims. It gives greater access. You have more frequent interactions with patients, helping them to implement the care plans to the better health outcomes. You can prevent admissions. You can prevent urgent care or emergency room use, and you can design it in a way that it is satisfying and gratifying for the physicians. So. That really is the going mantra in any design activities. But it's also about, obviously, the patient. 20 years ago, patients were concerned about quality and confidence. And that's basically where the academic medical centers mostly live. But then very quickly over time here, with a lot of out-of-pocket pay, and now being the Netflix generation and the Amazon Prime generation, where everything is on demand and we can get anything, anywhere, anytime, within just a few hours or a day, we also want convenience and value. And then there's some other concierge medicine and trusted PCP, large group practices. But the future leaders of healthcare, and it doesn't matter whether you're a rural FQHC or whether you're a larger health system or regional health system, what the modern healthcare consumer is looking for is all those four areas. They want quality care, they want value, they want convenience, and they want to have the confidence. And so telehealth is a great strategic tool from a leadership perspective to really address the needs and the changing expectations of the modern healthcare consumer. So that was the section of kind of making the case again for telehealth and telemedicine. Obviously, it's a great tool to keep staff safe, to keep patients safe during the COVID-19 crisis, and until we have determined the ways that we can safely socialize again. But for the time being, and even for the foreseeable future, I see that we will be living in a hybrid care environment where a portion of the care will be delivered virtually, because this is what the modern healthcare consumer expects, and because, frankly, because that's what's clinically absolutely feasible and doable. But then there's also the need for in-person care out of a variety of reasons that we'll go over here in the next slides. I always like to start with the end in mind. It's like, why are we doing hybrid care? What's the goal here? When can we say we're doing hybrid care successfully? And so in my conversations with CEOs and CFOs, it's about safely operating at full capacity again. That has been the direction for a lot of the healthcare organizations that I've worked with. And we want to get care to the patients when they need it, where they want it, and how they want it. I mean, that's what the most forward-thinking organizations have really embraced, that it's not just a stopgap measure to just keep everybody safe, but that it's really, it's a way to give patients what they want. Now, some patients, for example, I'm very aware of, don't have the connectivity, they don't have the technology. to connect in a rural environment. And so we need to find different solutions to do that. And I'll weave some of those in here as I'm talking about that, what we've come up with innovatively for some other rural clients that I'm currently working with. But it's really about operating safely at 100% capacity, because that's the driver here for the next 6 to 9 months until we have a vaccine, until we have a way to safely deliver care in close personal contact. So the definition then here, as a guide, everybody agreed until somebody defined it, is it's offering patients in-person and virtual care visits to keep patients, clinicians, and staff safe by using virtual care visits, with the intention to reduce the number of in-person visits so that we can adhere to physical distancing guidelines. It's really just reducing the capacity for in-person visits so we can safely see everybody and stack them in the schedule so that we can have safe physical distancing for all. And again, the goal is to operate at 100% capacity. We still want to see as much patient, or even maybe more patients than we were able to see before COVID-19. So why is hybrid care a great solution? And so I want to examine that from those 5 different aspects here, from the perspective of safety, from the perspective of cost, the flexibility that it affords, the patient needs that it satisfies, and then just the sheer pure viability of virtual care, as most of us, most organizations have experience. The first one is that with regards to safety, hybrid care is really great. All virtual care, as we've experienced, is not feasible because there's a lot of patients who don't, for whom the medical condition doesn't allow, they need to be seen in person for that. But most of the times they can be seen virtually, but then sometimes the technology or the connectivity stands in the way. And so that's really where hybrid care is a great strategy, a great solution to ensure physical distancing for the in-person visits by reducing the capacity in our limited physical environments that we have, by minimizing the exposure and the waiting room time. From a cost perspective, then, a lot of the concerns were about the availability of PPE that has been relieved here, but still there's a cost of PPE. There's changing them, again, depending on how contact intensive your practice and your specialties are. So obviously very different for behavioral health care than it is for primary care. There needs to be some intermittent cleaning and wipe downs, and again, we have additional steps in our workflows for the intake screening. I was talking to an FQHC in Florida last week, and they were saying we're going to be opening up here full again, but we have a lot of drop-ins, we have a lot of walk-ins. So how do we accommodate the walk-ins? And again, there's additional steps that need to be taken, and they all cost staff time, and with that they incur cost. And so hybrid care can be used to minimize the cost by offering virtual care as well as in-person care. The other consideration then about hybrid care is flexibility. And there's really 2 aspects of flexibility. There's flexibility on the part of the clinicians, and there's a flexibility on the part of the patients. For the clinicians, as a lot of them have experience now and are doing, they have the ability to work from home. Pregnant providers that want to work from home, providers that are based on the underlying healthcare conditions, immunocompromised, or that live with a family member. So for them, the ability to work from home, to still contribute to patient care and to be gainfully employed is really great. It also affords us the flexibility of different work shifts. We were so limited in our thinking that our clinics are open from 8 to 5, and now we have the ability to maybe have the virtual care visits offered in the evenings if that is something that the clinicians want to do, or on the weekends. Maybe they're caregivers, maybe they're parents, maybe they're new parents, and so they have certain numbers of hours that are available. It wouldn't be feasible to come in just for 3 hours, but it would be feasible to do 3 hours of virtual care visits. So really a lot of flexibility that we have with by using virtual care, hybrid care. And yeah, and it also provides the hybrid care model provides the opportunity to avoid telemedicine altogether. So I recognize that there are some clinicians who just are not going to be convinced that telehealth is something that they want to learn and get good at. And so there's going to be a certain percentage, and that's okay. With a hybrid care environment where we offer virtual care and in-person care, we can maybe have enough virtual care visits that they can maybe practice, have around a full-time practice doing in-person care if that's what they so desire. So again, it's having choices of virtual care and in-person care offers us that flexibility. From the patient's perspective, or I talked about that, the modern healthcare consumer, it's the choice of confidence and convenience, or as I like to put it, either technophobia. I don't want to deal with the technology, and I think it's weird to see my physician over video, to coronaphobia. I don't want to set a foot outside the door. I don't want to go into a healthcare clinic. And so that's again, different patients are going to have different preferences, and hybrid care gives us that flexibility to do both. Specifically to the patient needs here, many patients are avoiding going to the doctor, but they love the convenience of virtual care. And in all the satisfaction surveys we've conducted, again, if and when the technical problems had been taken care of, the actual interactions of the patients with the physicians are being appreciated by both the physicians and the patients. And so other needs are here that if you're COVID-19 positive, you don't want to go out and infect other people. And so how can you still get your own care? Again, that's where virtual care, telemedicine is great. And then some patients don't have the technology, but or trust in virtual care. That's the technophobia, and so they want to come in. So they want to be given the opportunity to in person, and then also that obviously not all conditions can be diagnosed virtually. Although for the most part, medicine has now evolved into clinicians ordering tests, ordering blood work, ordering X-rays, ordering specialty reviews, and so a lot of what very little that we do is hands-on, other than the vital signs of blood pressure, weight, and temperature, and maybe listening to heart and lung sounds, but very little these days is hands-on that we couldn't be obtained in some shape or form also virtually. So the last bullet point really is very rare that we come across situations where a diagnosis is not possible. On the other hand, what I always remind physicians of is like, if you can't make a diagnosis based on your conversation, what do you do? Well, then I order more tests or I get more information. Said, well, that's exactly the same thing with telehealth and telemedicine. If you don't feel comfortable after talking to the patient to make a diagnosis based on your interaction with them, your conversation, you can always say, I need to see you in person. I mean, it's our typical modus operandi here that we see patients multiple times until we can make an accurate diagnosis and care for them. So that's the opportunities here. And then lastly, the viability of virtual care. It's been around for 30 plus years. It's been really used very heavily in just in the last 10, 12 years that I've been in it, and patients love it, and physicians for the most part in the programs that I was involved with, they like it, they appreciate it, and it's I always ask the question in some surveys, was the visit as good as an in-person visit? And for the most part, I got like a 4.5, 4.3 on a 5-point Likert scale in terms of agreement with that statement. In some cases, even especially in the psychiatric world, sometimes it's deemed better. It's just easier also for people with a lot of comorbidities or transportation issues. It's better to see you virtually than not to see you at all, or having you go through the hassle of coming into the clinic, arranging for transportation, or for example, I worked a lot with nursing home residents as well. For them to be transported to be seen by a psychiatrist is a pretty big deal for somebody who lives in their own world. And so, and in rare cases, telemedicine does not work. So really, that's the argument why really every organization should embrace virtual care. So those were the 5 areas with regards to hybrid care. It affords us to do safe in-person visits. It helps us to lower the costs, because if we had to see everybody in person, we probably would have to rent additional space or and incur costs with additional PPE. It gives us the flexibility for physicians and patients, addresses the patient needs, and we can do it because telehealth truly works. All right, so on to the next section here, to implementing hybrid care. And I want to take a look at that from 3 different aspects here: optimizing in-person care, optimizing virtual care, and then implementing hybrid care. So the pattern here is that obviously you need to rethink how you're providing in-person care. You need to also optimize how you do your telehealth, telemedicine, your virtual care visits. And then when you bring both together, what are the considerations there? So starting with optimizing in-person care, and a lot of you have already done this and are doing this. And so it's about all the various different workflows with regards to screening patients when they come in, the intake process, the visit process, and then the discharge process, rethinking about how we can do this safely. You obviously want to optimize that for minimal interactions, patient to staff interactions, as well as patient to patient interactions, especially. One technique that some of you may have used is to kind of map out the patient movement here, or what we call the spaghetti diagram, just mapping, okay, a patient comes in the door here, goes to the check-in, goes to the waiting room, maybe goes to the toilet, comes back, and then goes to the room here, and then after discharge, where do we put them? So again, mapping this out can help you to identify where there may be crossovers between different patients that are at a different stage of their visits, and so it's a good visual tool to do that. And then obviously you probably already have in place standard operating procedures for PPE use and cleaning. Now that we're 6 months into this, 3-4 months, depending on when you launch this full scale, you want to go back and measure again. You want to measure that people are following the policies, that people are, maybe the policy needs to be updated. Maybe it was a little too stringent, maybe it was not very clearly defined, but periodically now going back and really making sure that everybody is following those guidelines and those policies is critical in terms of optimizing the in-person care experience for a safe experience. And then from a virtual care perspective, and in the PDF that you'll see uploaded to the presentation, I have an appendix here, and depending on how much time we have, I may jump into that later here. And I also have a white paper that I can send you when you reach out to me. But I identified kind of the 6 hallmarks of successful telehealth services during the COVID-19 crisis here. And I'm just going to talk briefly about them, and then you can see more in-depth material in the appendix in the PDF after the presentation. The first hallmark is that organizations who do telemedicine really well, who do virtual care really well, have recognized that telemedicine is a new clinical service offering. If you're an FQHC and you start offering dental services, or if you are a health system and you're starting to add rheumatology or endocrinology to your practice, what are the steps that you typically would have gone through to do that? How do we get paid? What are the billing codes? What are the specialists? What are the workflows? What are the policies? What technical diagnostic tools do we need for the specialty? And that is exactly the mindset that is needed for telemedicine. It's not as simple as throwing a webcam and a Zoom license over the fence and saying, hey, now go do telemedicine, because there's so many things involved in this. And that's that. So that is one hallmark here, is to really take a look at, well, if we had taken 3 months or 6 months to launch telemedicine, what would we have done differently? And based on that exercise, you can now go back and see, well, what can we now fix now that we know what we would have done if we had more time? And obviously in March, April, we didn't. We needed to launch virtual care so that we can still provide patient care and keep everybody safe. The second one is that really workflow needs to drive technology. So I call that putting the horse behind the cart, meaning buying the horse first, the technology, and then deciding what you want to do with it. A lot of organizations jumped in maybe with their telemedicine system of the EHR or Zoom, or some smaller practices. Even I hear rumors of people using FaceTimes or Teams to do telemedicine. And that may very well what your organization needs, but I invite you to take a little step back and say, what is really the experience that we want our physicians, our patients, our staff to have? How should this work? How can we mimic our in-person experience and transport it to the virtual world with regards to a rooming process, or with regards to doing a tech check, which comes here in a minute, of setting patients up? What can we do, and what are we looking for in the technology to support us with that? Obviously, it's HIPAA compliant, high quality video, but you can get that from Zoom or FaceTime or Skype. But then there's more to it, and it's all driven by the workflow. And so really identifying the workflow. A lot of organizations nowadays are revisiting whether the technology that they chose in April is really serving them well. And so this is exactly the time now to first look at your workflows before selecting on the technology. The third part is that there's a lot of workflows, a lot of policies, and a lot of different types of technologies involved, from scheduling appointments, from coding, telemedicine visits, that physicians and staff need to be trained on. And very few organizations did some really formal training. For example, I do a 10-minute website manners training to teach them the video etiquette on how can you present powerfully on video. What are the things that you need to do? Doesn't take much, but it makes a tremendous amount of difference in the clinician's confidence of doing telehealth well. I've seen that over and over again, that just by spending 10 minutes on giving them some pointers of looking into the camera, maybe commenting on some background noise or what's going on, or if they're looking at this screen versus that, and just these few pointers build up the confidence in the clinicians, and they are much better and much more comfortable in doing telehealth and telemedicine. So training is key. The fourth one, that is really very unique to this direct-to-consumer, bring your own device flavor of telemedicine, which is one of the most complicated telemedicine scenarios, and especially in rural areas. This fourth step is absolutely critical. So we've implemented that. I've worked with an FQHC in March 15th, actually implementing their school-based telemedicine system. And we had to, and the CEO turns to me and says, Christian, by when can we have telemedicine up and running for our 25 primary care providers at these 5 locations? And I said, you'll have it by Friday. And that was Wednesday. And what we instituted from day one is that at the time of the appointment scheduling, somebody interacts with the patient to make sure that they have the technology and the knowledge how to present on video, be in a quiet room, maybe have some earbuds in for privacy, don't have a bright window behind you. I mean, all these tips and tricks, and just figuring out that they are comfortable with the technology takes 5 minutes, but it made a whole world of difference with regards to the physician satisfaction as well as the patient satisfaction. And they ramped up back to 100% of pre-COVID-19 volume within 3 weeks. It was phenomenal to see how that worked. The fifth one then, and I talked about this a little bit when I mentioned optimizing your your in-person care processes, is you got to measure. You don't have to collect 25 measures or large dashboards, but there are some key performance success measures that you need to identify, whether it's physician satisfaction or whether that's with regards to billing and billability and rejections or declined claims, return claims. So metrics need to drive quality. So you need to periodically, maybe not continuously, but periodically measure, are patients still satisfied? Are physicians satisfied? What are the technical problems that we're encountering? And so really using those metrics to improve the quality of the telemedicine service. And then the sixth hallmark that people are doing is in anticipation of a whole flood of changes again, in the upcoming months with regards to what is permissible as a billable telemedicine visit and what is not. I recommend, and we've implemented, an internal pre-authorization step. That's not it's not a gate, meaning you don't have to, it doesn't have to clear before you can schedule the appointment, but it's to have processes in place where somebody looks at the incoming, at the new appointments, and does a check on whether this payer is still paying for this particular modality, whether based on the patient location that is permissible. So these kind of aspects, just doing a quick proactive check, that we don't end up doing hundreds of telemedicine visits, which we then find out because of a change in rules and regulations, we no longer get reimbursed for. And so that is really a very proactive step. If you're interested, I have a white paper, a PDF that I can send you. Just shoot me an email. I've got my contact information here later, and or you can just Google my name, Christian Malaster. It's down there. So, and I'll send that to you. All right, implementing hybrid care. Some more thoughts here on scheduling models and on work locations. Mentioned flexibility before, and so the scheduling models is that I differentiate here the Swiss cheese model and the block cheese model. So the Swiss cheese model is what I've typically used in organizations before COVID-19. It was about telehealth visits that were interspersed with in-person visits. I had an endocrinologist who had 2 exam rooms. In one exam room, there would be patient in person. She would see them, then she would wrap up, and then her nurse had teed up the next patient from a rural clinic 40 miles away. That was on screen virtually, and then she just moved over, saw the patient, and then was going back and forth. Worked really, really well. But then for COVID-19, really what I recommend is the block cheese model. That is really the ability to schedule all the telemedicine visits on block. And that, as much as a European who loves Swiss cheese and does not really care much for the block cheese, as much as I want to endorse the Swiss cheese, I have to say that I'm sorry, this slide has been messed up, so I need to fix that in the handout. But I am endorsing the block cheese for COVID-19. Meaning that you want to do block scheduling and you don't want to do the Swiss cheese model. Why? Because if you were to have an in-person visit and then you have a virtual visit, it's the changes of PPE that are really standing in the way and that are making this very stressful. There were some physicians that I worked with. One was at the Cleveland Clinic. And he said it's just what was so stressful to do like 3 in-person visits, and then I had this telemedicine visit, and then I went back and said, no, you got to schedule them all on block for the afternoon or for the morning. Because the beauty of virtual care visit that I haven't even mentioned here is that you don't have to wear any PPE. We can just be on screen like we're now. We're not wearing masks. We're seeing our faces, our facial reactions. And that also is the beauty of a virtual care visit as well. So definitely use the block cheese model. You can have physicians work from home in the morning, do some telemedicine visits, and then come in for the afternoon for some in-person visits. And then you can have other providers that you flip around. And so again, that's how you manage your capacity in a hybrid care environment, that some work mornings from home with telemedicine, some work from there. Okay. Oh, there's the slide, sorry. So I approve of the block cheddar and I'm rejecting the Swiss cheese model. So just ignore the previous slide. I knew I had it in here. The other considerations here, so obviously you need to involve, and all of you are probably already doing this, buffer times between the in-person visits for personal hygiene and PPE changes, so you can't schedule them back to back anymore. And you need to also minimize the virtual wait times. Patients in an online environment have very little patience to wait for 15 minutes without not knowing what's going on, staring at the screen, and even worse in some video systems, staring at yourself for 15 minutes feels like really, really long. And so you need to institute different processes that maybe after 5 minutes, they can call you and then you can let them know when the physician is close to it. Some other organizations, even though my appointment is at 3 o'clock in the afternoon, maybe I wait for the nurse to call me and said, hey, Dr. Miller will be ready for you in a few minutes. So I want to go over a few things. So one organization I work with, they have a tele-rooming process that calls the patient when the physician is close to getting ready. Because as we know in healthcare, physicians do run behind, even on a telehealth and telemedicine visit. Good. Then the second aspect here of implementing hybrid care that I want to talk about is, is the work location. So again, allowing and encouraging clinician staff to work from home, to decompress the number of people that you have in your buildings to keep them safe. Maybe part-time remote work, half days, as I just mentioned, or full-time remote work for staff at high risk. And very important, as many of you probably have learned, if not really think about this, providing the technical and especially the emotional support. It can feel very disorienting to be so far apart for a long time. And that's why that second bullet here, the part-time remote work, is really, it's a great hybrid model too. So yes, you get to work from home and do all of that, but you also get to get in the clinic, you get to see people, you get to interact with them, because there's just different, it just makes a difference, as we all know and experience, that virtual only works for so long. And then we really got to see people in person. And then the other considerations here from just a physical perspective is that you can also convert some of the exam rooms into telehealth rooms. Meaning that a physician who's there, maybe they can't work from home, maybe they don't want to work from home, maybe they live farther away, maybe they have 3 kids that are doing remote learning, distance learning from home, whatever the circumstances are. So still you can do maybe your in-person clinic in the morning, and then you just go into one exam room and you just have telehealth and telemedicine visits. And so maybe there's just some considerations with regards to your background, with regards to the lighting, how to sit, that you want to consider to turn an exam room into a makeshift a telemedicine room as well. And then the last point here, that was really a creative idea. I was working with a mental health agency in Rutland, and so we ran into a lot of problems with the clients of those clinicians having access and connectivity problems. And so what we instituted there for them is a drive-in hotspot. So we put a Wi-Fi signal out on the parking lot so they could drive up. But then a lot of patients also don't have transportation. And so what we did there is we have a designated kind of walk-in telehealth room where they could then see the provider who was still working from home because she could not get exposed to it. So that's there. So good. All right. We're a few minutes away from the Q&A, so I'll take a look at the questions here. So the key factors is that hybrid care is a workflow challenge from a scheduling perspective, from how do we move patients through our building, mapping the workflows, designing new workflows, then offering training and support for the new workflows, for the technology, for the scheduling, for the different communications. That is really key in order to have successful hybrid care model. The other aspect is that, and I actually just, I write a weekly newsletter in which I cover one topic every week. And last night I wrote about organizational change management. So on my website, you'll see that article posted here. And I'm using the ADKAR model, which is really great. It stands for awareness, desire, knowledge, ability, and reinforcement. And so people need to be aware of why the change is needed. They need to have the desire to change. They need to have the knowledge how they can change, the ability to change, and then there needs to be reinforcement. And if you have all 5 elements in place, that's when you get sustainable change. The interesting things that appear is that if you are not aware of why we're doing this, then there's confusion. Now, nobody could claim ignorance with telehealth and telemedicine. Everybody knew why we were doing it, to keep everybody safe. So that went away. But before COVID-19, that was something that I worked on with the CEOs and the leadership team to really raise the awareness of why an organization wanted to do telehealth and telemedicine. The second aspect then is desire. And if people don't have desire, they are very resistant, like this animation here coming over to the right side. They're resistant in terms of wanting to change if they don't have the desire, if they really don't buy into it and don't see the benefits. The knowledge aspect, then, if you don't have the knowledge, if you don't really know how to do things, then you're reluctant. You don't want to make mistakes, especially our clinicians that are so used to being in charge and in control, and suddenly now they need to do something that they've never done before, and they don't want to, like any of us, don't want to look stupid. They don't want to make mistakes, and so if they don't have the knowledge, they're very reluctant to do it. And sometimes all it takes is a little bit of training, like I did the 10-minute training for website manners. Then the ability, training them on, well, how do you schedule an appointment? Well, physicians shouldn't be scheduling appointments, but how you join the video room, how do you do e-prescribing or whatever is involved in the workflow, training them on how to do that. Because if you don't know how to do things or how to do them well, then it leads to frustration. And then the last one is reinforcement. Again, the measures, the metrics, in order to prevent some backsliding. So really a powerful mindset tool to really look at, okay, as we're trying to overcome some resistance or reluctance or confusion, what are the things that we can do here on the left side? Can we raise awareness? Can we provide some better knowledge? And so it's a very great just a planning tool for identifying what you can do. And with that, right on the spot here, I have time now for 7 minutes for Q&A here. Let me actually, Katie, do you want to read out the question? Because you read ahead here and pose it to me.
Yeah. So there's two questions that are very much the same. And again, everyone, if you could just submit your questions in the chat, we would appreciate it. So two folks asked about if you have a document or checklist with tips and tricks for optimizing the telemedicine experience for both the clinician and the patient. If you have anything like that, it would be helpful.
Okay, and somebody seconded that. So yes. Yeah. Well, we would have to dive in a little bit deeper to really understand the question, because that was my intention by providing those 6 hallmarks, because that is kind of the checklist. But I think you may be wanting to go deeper. Again, optimizing the telemedicine experience. Let me just take that apart. Or if you want to add some more text to it, or if you just want to unmute yourself, Deirdre, and explain that, that would be great too.
We are not having anyone unmute their lines.
Got it. Okay, that's
chaotic. But I can certainly connect you to the two of them, or Deirdre or Rebecca, if you want to expand a little further, you can do so in the chat.
So for example, I mean, because there's so many aspects to it, right? There's, well, not so many, but one aspect is the technology. I mean, obviously, does the technology work? Am I comfortable with the technology? Can I clearly see and hear the patient? Can the patient clearly see and hear me? And so that obviously is a checklist, and that I usually explore in form of a patient survey, and as well as a clinician satisfaction survey. Okay, optimizing the telemedicine experience. It's also about the telerooming process. So I brought that up 3 months ago about what is your process for rooming the patient at a distance. Nowadays, it's just, well, you receive an automatic email and you click on the link and then you're in the room. That's our rooming process. Well, that's not that's not really a good rooming process, because it doesn't mimic anything that we're doing currently in the in-person world. That's actually another mindset that I encourage you to explore. Is like, okay, what are the steps we're doing for in-person care, and how are we mimicking these steps in the virtual care environment? And again, that's where you can also look specifics we can give to the patient. It is in that tech check process. It's make sure you don't have a light behind you. Make sure your conversation cannot be overheard. You don't have any background noise. So that's the audio, that's the visual. Again, some normal encouragement. Make sure you have a list of questions you want to ask the physician. That applies to in-person visits as well. You may, depending on your technology may have the ability to do a self-check. If you're using Zoom, you can go to zoom.us/test and you can direct patients to it, and they can do a little self-test. And other technologies have similar functionality. So it's about checking the technology, being aware of the environment. The other thing that I have in our what we develop, and again with every organization it's different, but we said, Mrs. Smith, you're having your visit here with Dr. Miller next week. I see you're in your kitchen. Is that what you want Dr. Miller to see? And that's when the first time the patients realize, oh, wow, I'm inviting my long-term physician into my house. Okay, I got to be mindful and careful about what I want to show or not want to show. And so those are some of the things. The 10-minute video training I discussed, I don't have that readily available, but you can reach out to me and we can think about that. So that's something I've custom developed for my clients.
We do have a question that was a little further up from Morella. Can you please speak about the reimbursement some more? What are the biggest challenges, and are payers keeping up with the change?
That is a whole presentation in itself. So, but yes,
I know.
because there's Medicare, there's Medicaid, there's commercial insurers, and then there's New York. So having worked a little bit with New York, having had a little bit of insight is to, seems like a lot of organizations in New York are very reluctant and are trying out to only reimburse 40 or 50 cents on the dollar. So, yes, reimbursement. Overall, I'm very optimistic on Medicare and in general on Medicaid. Again, I haven't looked in depth into New York Medicaid because I haven't had a recent client there. But Medicare, I think the rurality requirement, the in-clinic requirement that used to hamper a lot of telemedicine is going away. It's going to stay away. And I actually have a whole segment of a presentation where I lay it out all in the table. And maybe at some point we can weave that into maybe one of your educational offerings. I can come back for just an intermittent monthly webinar or something like that. And then your crystal ball is good as my crystal ball, right? I mean, it's obviously highly political, and that's why I'm highly encouraging you to do that 6th hallmark, the internal pre-authorization. Stay on top of it and designate the 2 people in your organization to subscribe to all the different sources that there are. The telehealth resource centers have a national policy thing. Use resources like Katie here. To help you because they disseminate, they screen all that information and they can give you the latest information, but have a designated point person that can look at the daily reports of scheduled visits to make sure they're still reimbursable. So that's, and then our payers are keeping up with the change. I'm hearing happy day scenario stories and I'm hearing horror stories. So it's all ends of the spectrum. So that's what I can say there. So.
I think we have time for one more question from Margaret Greenfield. We have heard recently that if a provider is seeing patients via telemedicine at their home, the facility fee is less than if they were performing the telemedicine visit from their office. This is promoting providers to get back into the office as the hospital has high reimbursement. What are your thoughts then on how this affects the hybrid model? It's a great question.
It is a great question because ultimately it's dollars and cents that are going to drive any kind of model. And yes, I think it's almost a leading question. So first of all, I disapprove of that. On the other hand, we also need to recognize that, however, a virtual only provider that has no brick and mortar, which can is almost like anybody can now open up a virtual care clinic, hire some physicians and offer it online, and they don't have any facility fees cost. So yes, I think for those providers who do have facility cost, they should get more reimbursement than just a virtual only visit. And so I don't, and yes, it could be seen as enticing people to go back to the in-person model. And I know some conservative medical state societies are still not really on board with telemedicine as the long-term solution for receiving care. And so they're trying to push their agenda through these regulations. But yes, I don't think that's good, but it's going to be the reality. Here's the other reality, is that if you then decide, well, sorry, we can't see you virtually anymore. You have to come in now. You don't tell them that you get paid more, but that's just what you declare. They will have alternatives. They will have alternative virtual care providers that they can go to. And so you may over time actually lose that patient, because now everybody can see somebody if they just want something, if they want that convenience. And so it's a very careful decision that you need to make, because the modern healthcare consumers is going to be acting very, very differently. So good.
All right. Well, I will let you lead us out with some closing thoughts.
All right, great. So we'll wrap on the bonus. So just some summary slides here. Telehealth is delivering care at a distance, and telehealth is really a new clinical services offering that requires new workflows, new policies, training support, marketing publicity, designated leadership, change management, I mean, all these things. And if you haven't done them really, as probably now's the time to go back and do them. It's never too late to optimize something that's being rolled out. Hybrid care is delivering care at a distance and in person. It's, in my opinion, the new way to deliver clinical care. And it requires coordination and communication with regards to the schedules in the room and all of that. And we are introducing very new paradigms to healthcare with regards to the work location of the clinicians, the location of the patients, how we're doing the scheduling. And you need to identify some designated leadership, because if it's a new clinical service offering, it should have a new clinical leader. So a medical director of telemedicine, as well as maybe a telehealth program manager. And it requires active change management. And the one kind of success accelerator that I want to leave you with, and I hinted at that at the previous slide here, is that really I encourage you to identify who is in charge of your telehealth service offering, because it takes a different mindset to think about telehealth and telemedicine. First and foremost, you need clinical leadership. You need a clinician to be at the helm. This is a clinical service offering. This is not an administrative process. This is not a billing process. This is not a technology process. This is a clinical way to deliver medicine. And what I'm working with some clients in Vermont now on is actually developing clinical guidelines as to when is telephonic appropriate, when is video appropriate, and when is in-person appropriate. What are the clinical guidelines for our organization, for our specialties? And so again, that requires clinical leadership. You need to have operational leadership, obviously, to support the processes, as well as technical leadership to provide technical support. And ultimately, the buck stops here. It needs to be at the executive level. And all of those four need to work together in the form of maybe a telehealth steering committee. Again, doesn't require much time, but it's that conscious mindset to do telemedicine well, is that there's clinical leadership, there's executive leadership, and then obviously operational and technical support. With that, I thank you. Sorry for the font mishap here. Appreciate the opportunity to talk to you. Reach out to me. I have a lot of information that I'm sharing freely through the various channels on LinkedIn. I have my newsletter, which is sales and ad free. And really, my mission is to share all the things that I'm learning with the community at large. If you have an opportunity to engage an outside expert like ourselves, obviously that would be great. But at a minimum, you can benefit from what I'm learning with the clients who have engaged me. I also, I don't think I have it on here, am running a telehealth community. It's telehealth.community, and it's an online forum for everybody to join and exchange ideas across the nation. And so, because really telehealth is here to stay, and we can all benefit from learning from each other on how to do that better. So connect with me, reach out to me. Always interested in, always willing to do a 20-30 minutes session or just a meeting to answer some questions. Here are some of the articles that I've posted here over the last year, and with that, then in the handout you'll have this addendum of optimizing telehealth, which is the six hallmarks that we talked about before.
Excellent. Thank you so much, Christian. We had great participation today. So again, if any of you want to contact Christian, his information is on the slide. That wraps up our morning session for today. We hope you'll join us at 2 p.m. this afternoon for a session featuring Andrew Spadoni from MVP Healthcare. With that, we will see you later, and thank you again, Christian. Have a wonderful day.
Thank you, everybody. Thanks for joining, and thanks for the people who were on video. It was nice to have a little bit of an audience. And
Yeah.
Jared, I love your background. I felt like I was looking over Lake Placid. It is okay. Well, great. Okay, wonderful. Good.
All right. Have a good one, everybody.
Okay,
Bye-bye.
thank you, everybody.